Good evening, everyone. My name is Leanna Levine Reisner, and I'm the Network Director of Plant-Powered Metro New York. Thank you so much for joining us for the second session in our month-long series, Women's Wellness and Food, Reproductive Health Throughout the Lifespan. At Plant-Powered Metro, we are dedicated to your health and empowerment, providing evidence-based nutrition education and support for meaningful and sustainable lifestyle change. We focus on the tremendous power of eating whole plant foods to change our health trajectory. As I mentioned last week, I lived with endometriosis for 15 years before discovering that whole food plant-based nutrition alleviated and nearly eliminated my symptoms. While I'm not alone in this discovery, the truth is that most of us go through life just managing our health and never learning how to get into the driver's seat. If that's you, then tonight's session is for you. Last week, we met Dr. Padma Garvey, who offered foundational information about gut health and vaginal health, setting the stage for deeper discussions with each OBGYN to follow, who are addressing different angles and stages of women's health. Our goal is to offer you new insights about women's reproductive health and the most practical tips that can enhance your well-being. A special thanks to our collaborating partner for this series, Dr. Nasolo Teddy and the HeartSmarts community, which inspired this project. Dr. Teddy will join us next week and in our final session. Tonight, we explore nutrition and fertility, pregnancy, and childbirth with Dr. Melinda Mann. I have to say, I have deep, deep respect for Dr. Mann, who has been a passionate voice for nutrition empowerment in many communities, and especially in the ultra-Orthodox Jewish community. Dr. Mann is an obstetrician, gynecologist in Brooklyn, and has over 30 years of experience in the medical field. She graduated from New York Medical College and is affiliated with Maimonides Medical Center. She also serves on Plant-Powered Metro's Medical Advisory Board. She's passionate about helping newly pregnant women understand how their food choices will affect the next generation. Dr. Mann has her own journey. In December 2018, Dr. Mann became plant-based overnight after reading Dr. Garth Davis's book, Proteinaholic. She lost 50 pounds easily and for the first time in her life was able to maintain her weight loss, later going on to become board certified in lifestyle medicine. She's a co-founder of the new organization K-Plant, bringing nutrition education to kosher consumers in Orthodox Jewish communities. Welcome, Dr. Mann. It's a pleasure to have you.
Thank you so much, Leanna. I'm so humbled to be part of this important series. I just also wanted to add one comment about going plant-based, that when COVID hit, I was already plant-based, and I truly believe that my life was saved because COVID attacked my heart. And then later on, when I had COVID again, it attacked my thyroid, but I was able to weather the storm and I got through. I was not hospitalized and I did well, and thankfully I am doing well. So I'm so happy that I was able to get through that. I don't know what would have happened otherwise.
Yeah, absolutely. And the benefits for the immune system are just phenomenal. I know we're going to dig in on some really important topics for women of reproductive age. So let's get started. What can we learn from you tonight?
Great, thank you. So the name of my talk tonight is a new name, is The Changed World of Today's Reproductive Age Woman. So we have care throughout the reproductive lifespan. I'm going to touch on all of these topics tonight. Some are going to be more at length than others. We are dealing with more hormonal imbalances than ever before. Part of it is due to food and lifestyle. And then we're also having these so-called endocrine disruptors, which are in our environment. We have preconceptual care. If someone can figure out to come to the doctor before they have a positive pregnancy test, we can do a lot of interventions there. We have antepartum care, or what we call prenatal care, 9 months of that, hopefully. Intrapartum care, which means labor and delivery, and postpartum care. We have the immediate postpartum, and then we have, usually they call it up to 6 weeks postpartum. So in the backdrop of all of this now is obesity and compromised metabolic health. And this has really changed how we approach taking care of women. In fact, there was an editorial, what is the role of the OBGYN in preventing and treating obesity? So it's definitely at the forefront. And I'm very hyper aware of it, and I'm thankful that I'm in lifestyle medicine. I just look at everybody with a different pair of glasses. So this is where I work in Brooklyn, and this is what I do. I practice and teach bedside medicine, and it's a different way. We leave the computer out of the room. We go in there and we actually talk to the patient. We examine them, we discuss, and then finally we come up with what might be wrong and we order tests. So this is what we know, that our food is the number one cause of poor health. Number one is dietary. Number two is tobacco. Number three is blood pressure. Number four, obesity. It's all linked together. This is from the Global Burden of Disease, Bill and Melinda Gates, and basically talking about death, and they call it incapacitation, which means disability, but it's the same. Diets high in sodium and diets low in whole grains, and it's the same thing here. They just swap diet low in whole grains and diet high in sodium. And to recap, we have our microbiome that's been discovered in recent years, these trillions of microbes that live down there and digest our leftovers. The good bacteria eat fiber and make short-chain fatty acids, which improve our health. And there's actually a whole society going down there. When you do go down, you'll find, when you analyze, the poop, that you have the good bugs and the bad bugs. And the good guys like to eat fiber and make all sorts of health-promoting substances. And the harmful bacteria love to digest animal leftovers, and that leads to inflammatory changes like leaky gut, etc., and is unfortunately disease-promoting. We know that a perturbation or a disturbance of the microbiome is associated with chronic disease, and you can see all these diseases here. What is the antidote? Lifestyle medicine, healthful eating, physical activity, managing stress, forming and maintaining supportive relationships, improving our sleep. I'm not going to tell you until what time I stood up last night fixing these slides, and avoiding risky substances. There are many, many ways to dive into this lifestyle. One is to go with Michael Greger. He has an app on the phone. I'm just putting that up as an example. He lists everything you need to do in a day to be healthy and pursuing a plant-based lifestyle. But this is a very interesting slide. Dr. Mozaffarian, he is an expert in nutrition, and he's not purely vegan or plant-based. Sorry for the squeaking. Hold on, please. Excuse me. Squeaking. Need a little, we need a little comic relief. So if you look at the arrows, the blue arrows and the blue arrow and the red arrow, and you see up at the top, fruits, nuts, fish, vegetables, plant oils, whole grains, beans, and yogurt. This is going to give you the most health benefit. And if you look down at the red, what is the worst thing you can eat? Refined grains, starches, sugars, processed meats, high sodium foods, and trans fats. And then you have kind of in the middle up there, cheese, poultry, and milk, maybe a little okay. Eggs, butter, and unprocessed red meats, not so good for you, but you can enjoy those in moderation, presumably. But what's really interesting about this, and when I was looking at it, if you look and draw a line on what is the most health promoting, you see up at the top, there's color, which is the phytonutrients that benefit our health, and the fiber, but the rest have no color and no fiber. So to guide your food choices, you want to do the color and the fiber. So I say, when people ask me, what's the best book to read? I think that this is the best book to read. Do me a favor, just get this book. Patients come to me, they say, Dr. Mann, I'm pregnant. What vitamin should I get? And I say to them, the one your insurance will pay for. Or they'll say to me, Dr. Mann, I'm pregnant. Do you think I should take an omega for my baby's brain health? And I answer them, do you think Einstein's mother took an omega? Do you think Martin Luther King's mother took an omega? No. Or they'll say to me, Dr. Mann, what should I eat? What should I eat? I'm pregnant. And I say to them, give me a food diary. Let me see what you're eating. We're going to have to fix it up. So usually I try to recommend the book. And this is really a beautiful book because it's for families. And that's what we're about. We're about families. Now we're going to get more into the high BMI issue of what we're dealing with. We know body mass index is commonly used to categorize patients. Actually, Lancet, which is the British journal, just came out and they said they want to throw away BMI, but we're still going to keep BMI because it's helpful. So if you look down there, you'll see obese is BMI 30 and above. Then you have class 1 is moderate, class 2 severe, and class 3 is extreme. With a BMI of 40 and above, these people are really fat. Excuse me. I like to use the term high BMI. That's how I refer to them. Now, it's important to understand that in this day and age, we are routinely seeing women with BMIs in the 50s and even 60. Every Sunday, I go to labor and delivery, and every Sunday, there's somebody there with a BMI in this range. The majority of these women are brown and black, and taking care of them is not easy. A vaginal birth is not easy, and a cesarean is not easy. Let's talk about labor and delivery for a high BMI patient. And this is a true story. It happened about 3 weeks ago. 7 in the morning, change of shift. Sunday morning, I came on duty. A woman having her second baby, her BMI actually was 49.9. She didn't make 50. Okay. She was being induced for diabetes, preeclampsia, which is complicated high blood pressure that could theoretically lead to seizures or strokes, and severe polyhydramnios, which means she had excess amniotic fluid. And she really had excess amniotic fluid. Normal's up to 25 and hers was 40. So they induced her for 2 days. It went on forever. And finally, she became fully dilated right before I went on duty. So I got a call from the nurse. The patient's in a lot of pain. And the doctors and the nurses at 7 a.m., they're all in sign out. But I leave sign out. I leave. I didn't want to leave sign out. I enter the room, and the anesthesiologist is there. He's about to give a top off, which means he's going to give extra anesthesia to numb her so she shouldn't feel anything. Because frankly, that's what's commonly done on the change of shift. Not all the time, but it's a strategy. So I asked the anesthesiologist to hold off. Can you please hold off in the top off till I check the patient? So I checked her, and she was really ready. I thanked the anesthesiologist. I waved them away. So the first principle in high BMI women, do not delay delivery because you don't know what kind of trouble can happen in those even few minutes while you're waiting to get this baby out. And please don't give a top off because you're on the change of shift ever, but especially please don't mess around with high BMI women. I want to just stop here and apologize for my black and white slides. Usually I try to keep them colorful, but there's a lot of narrative here and not a lot of time. So I assess the patient, and this is my assessment coming in as a physician. Number one, the epidural is running, but it's not really holding her. Her pain score is high, but she's close to delivery, so let's just get the baby out. Her blood pressure and pulse are okay, but she's breathing rapidly. She's anxious. Her urine looks concentrated, which is completely normal. Number one, she's been induced for 2 days. And number two, high BMI women are chronically underhydrated. It's been suggested that high BMI women need double the amount of maintenance fluid. So between the induction and the high BMI, her urine, I call it the Snapple urine. Her Venodyne boots are on. Those are the cuffs that go around the calves to prevent blood clots from forming, to keep the blood circulating because she cannot move. And she's been laying in bed for 2 days. The fetal head is in a good position. The heart rate of the baby is reassuring. The father of the baby is the only support person. There's no doula, no female friend or relative, but I have a good nurse. So what did I do? First of all, I gave her fluids. And then I gave her oxygen. I told her, slow the breathing down. And the nurse said to me, why are you giving oxygen? She's saturating 100%. And I said to the nurse, look at her rate of breathing in order to maintain that saturation. Let's help her out and give her the oxygen so she could slow her breathing down. This is what you call bedside medicine. So the nurse is looking at the computer. She sees it's 100%. So she doesn't think that maybe she needs oxygen, even though it's 100%. And the answer is, I routinely put oxygen on all high BMI women when they're in the second stage of labor, which is the pushing stage. And often I give it to them when they're asleep, when they have the epidural and they're still dilating before the second stage of labor. I made eye contact with her and I told her to calm down and everything is fine. I made eye contact with the father of the baby. I gave her apple juice. I treated her with respect and dignity because unfortunately a lot of these patients, they're not treated properly. And then I started my task of rearranging her body. What does that mean? I needed 6 people to help me rearrange her body. And this goes on all the time. I use the old-fashioned stirrups so the patient does not have to support her own legs, and also to maximize the space for the baby to be born. That's called the pelvic diameter. We needed 2 people to lift each leg into the stirrups. And since we have to flatten her out to make space to get the baby out, I assigned someone to hold up her head. And then all of a sudden, the chief resident showed up. He spent the whole night attending to her dysfunctional labor, and he really wanted to see if this baby really can deliver safely. I told him to go home and go to sleep, but he said, no, I'm staying. Okay, she pushed. Only 5 pushes. The head delivered in 15 minutes. Now, what has to come next? The shoulders. And this is the fear of every obstetrician. In a morbidly obese, or what I call high BMI patient, are the shoulders going to come? So I said to the resident, don't wait for her to push the shoulders out. Let's start the maneuvers now. Get the posterior arm, get control of the axilla, which is the armpit. But he's a resident, he can't get it. And then the nurse starts talking in my ear. It's 40 seconds since the head is out. And despite the fact that I really want the resident to finish the delivery, I take over and a beautiful baby is born, APGAR 99. Please don't ask me if it was a boy or a girl. I do not remember. And everyone in the room breathes a sigh of relief because the shoulders did not get stuck. And I have to tell you, I have another zillion stories. And they're all a little different, but they're all kind of the same. So let's talk now about, again, with this idea of obesity and metabolic dysfunction that's permeating society right now. Let's talk about sign out. What's sign out? This is sign out. The night shift, the day shift, these are residents. These are Maimonides residents, and they're sitting around talking about patients for a full hour, if not more. I have to tell you that when I was a resident from 1985 to 1989, sign out lasted maybe 10 minutes. Now sign out lasts more than an hour. And I want to show you an example of what they're dealing with. This is filled with innumerable amounts of data about every patient. There are so many hypertensive women. There are so many diabetic women, and you can have 10 pages of this. You have women in the ER, on the antepartum service, in labor and delivery, postpartum, all with vital signs going out of control, all with blood sugars going out of control, all getting pushed beta blockers because they're getting severe range blood pressures. And this is the epidemic that we're seeing in society is coming into labor and delivery. It's coming into the hospital. More about what goes on in labor and delivery. This is a labor bed. We can break it. That's the feature of a labor bed. We can break the foot of the bed and put the woman in stirrups to deliver. Every labor bed has this red button. It's the CPR button. In fact, all hospital beds have a CPR button. But we know that it's something that is always on our mind as OB doctors coming into labor and delivery, that anyone who walks in might need CPR, and we're all trained in it. We're trained also in advanced life support. We have anesthesia with us, and we work as a team. And it's inevitable that it will happen that we will have to administer CPR at one time or another. So let's go back to 1992 when I was a junior resident. I had a nice Italian girl named Emily Bolin. This was way before the times of HIPAA when we weren't allowed to say anything about anyone. And anyway, Emily Bolin and I are best friends forever. But let me tell you about Emily. She had 2 previous cesareans and she was coming for her 3rd. Her BMI was 24. Most people had normal BMIs in those days. So she came in for her scheduled cesarean, and it happened to be that the anesthesiologist had some sort of premonition because he put 2 huge IVs in her. We started the C-section. We got the baby out. And then all of a sudden, the anesthesia resident said to me on the other side of the curtain, "Dr. Mann, there's a flat line." And I said, what are you talking about? There's a flat line. So she said, "Dr. Mann, she's in cardiac arrest." And I took a deep breath and I said, "Is this happening? Is it really happening?" And I said to myself, this has to be an amniotic fluid embolism. What's an amniotic fluid embolism? When someone is alive and then they're dead, basically the number one diagnosis is amniotic fluid embolus. It means some of the amniotic fluid escaped from the uterus into the bloodstream, made its way into the lungs, and this fluid got into the lungs. Now, what's in this fluid? There's debris in the fluid. There's fetal hairs. There's fetal skin cells. There's vernix, which is the white waxy substance, and other waste products from the baby. And once that gets into the lungs, it just causes a complete cardiovascular collapse and uncontrollable hemorrhage. So in addition to this patient being clinically dead, she was bleeding from everywhere. And so we knew what we had to do. We knew what we had to do. And in fact, just to let you know, the main risk factor for amniotic fluid embolism is a cesarean section. So we were like lions then. We just jumped on the patient. The whole hospital came, and there were maybe 30 people in the room. And I just had a little fun with my Canva here, and I showed this lion doing CPR on my patient. But if you look at the top, the patient was clinically dead, and actually she had an out-of-body experience. We worked on her for a very, very long time, but I'm happy to say that we got her back. And I can't describe the feeling of what happens when you have return of circulation. It's called ROSC, return of spontaneous circulation. Of course, they didn't call it that in those days. We just got her back. How did we get her back? So this is an ambu bag. This is what we use when a patient is intubated. That means the tube is going into their lungs, and we have to force the oxygen and air into their lungs. And when they're being transported, usually we use the ambu bag. But when they're in the operating room and they're hooked up to the machine, we don't need the ambu bag. So I was with the co-team leader looking up and down and thinking, why isn't she responding? What can we do to bring her back? What more can we do? I'm not giving up. I'm not making this baby into an orphan. And I noticed that the patient was on the respirator machine, and these machines are set at a certain rate. And I was looking at it and I'm thinking to myself, that's too slow. We have to do something. So I said to the chief anesthesiologist, Dr. Eddy, could we maybe take her off the machine and bag her? Let's try to bag her at a rapid rate. Let's see what's going to happen. And we started bagging her. And within a short period of time, she came back. So since that very day, I'm always hyper aware about respiratory status in obstetrical patients. And I want to tell you that high BMI women at rest, they have what we call tachypnea. They're even breathing rapidly at rest because they need to maintain their oxygenation. And it's very difficult to incorporate all of these ideas when you're taking care of high BMI women. But I would love to do a research paper on that. I don't have the time, ability, or any of that. But if any of you know someone who would like to do a research paper on high BMI women and their respirations in the 9th month of pregnancy, I would be very interested. So this patient got 60 units of blood products. She was 1 month in the hospital, and she needed 2 more trips to the operating room. Her memory of her out-of-body experience faded over time. And after that day, I made 3 resolutions. I would forever go to every code when I was in the hospital. I would help anyone with anything, and I would try never to do an unnecessary cesarean. And I really stuck to that. So let's fast forward now. We're post-COVID. I have her patient. Her name is HH. I did that. I call her HIPAA. We're not allowed to say anything. And her BMI is 50. HIPAA does not permit me to share details, but I will say that I was involved in her care, and her skin was not white. And I just want to tell you that this is me at the end of that long, exhausting, heartbreaking day. And I'm still crying about it. I wrote a poem and I still read the poem over and over again. It helps. It's a form of journaling and self-care, but this is the reality of the situation. So we have a lot of initiatives. This is a Safe Motherhood initiative that was started in 2008 by the World Health Organization. These so-called maternal safety bundles where they want to standardize care. So there are 6 bundles now. One is the Muse, which means if a mother has an abnormal vital sign, that's going to start a cascade of a response. Obstetric hemorrhage, we all know about that. Severe hypertension, which is rampant now. Venous thromboembolism, which is blood clots, and usually in the legs that travel. Sepsis, we do jump on sepsis because we have a window of opportunity to start antibiotic therapy before the patient goes into shock. And of course, cardiac conditions in obstetric care, which are actually more common now because a lot of women have had congenital heart disease and they have survived infancy, they've had surgeries. And so these represent a special category of women who need help in pregnancy. And in fact, there is such a clinic at Columbia for this. As well, we have something now called COS, and this article actually came out of my own institution, Maimonides Medical Center. It was published in the Gray Journal, which is a premier journal of OBGYN, and they focus a lot on research. So this article was authored by 2 maternal fetal medicine specialists, a hospitalist, and my chairman, and 1 GYN oncologist. So this constitutes the team that is going to take care of complex obstetrical surgery. Now, the comment that I want to make about this, about the Safe Mother Initiative, and also articles like this and different trends in care, and also looking at obese women, is there's sort of, I call them like a dam. Think of what a dam is. It's a structure. It could be very, very strong. It could be built by the best engineer, but there are times when the dam does not hold back. And that's what's going on right now with high BMI women. All of these measures that we are creating, all of these checklists, all these safety protocols, on and on and on, may not be enough to hold back the morbidity and unfortunately mortality of the high BMI patient. And that's why I came here today to talk to you, because I want to increase your level of readiness for change. I want reproductive age women to get more attention than they have been getting. And I would like to bring you, let's say, from pre-contemplation to contemplation to preparation, action, and let's get the show on the road. So what can we do? Let's go backstream. We can do preconceptual counseling, which is extremely valuable. However, almost half of all pregnancies are unplanned. And often the couples who need it the most are the least likely to come. Who comes for preconceptual counseling? People with a normal BMI, they're married, they're financially stable. They come to the office, they're like, Dr. Mann, we're thinking of starting a family in 6 months from now. What do you advise us to do? And, you know, we know who we need to get into preconceptual counseling. And so the couples who need it the most are sometimes the least likely to come. And sometimes it's not even a couple, frankly speaking. And it's a very important time to screen for metabolic health, as well as carrier states like sickle cell, vaccination status, et cetera, and getting them on the right vitamins. And then, of course, we have antepartum care, which is when most of our patients show up. So if we have a high BMI patient, we really have to treat them differently. And here are some of my suggestions. For high BMI women, what do we need? We need therapeutic intensive lifestyle intervention. Remember, I mentioned the 6 pillars of lifestyle medicine, and now there's probably going to be a 7th, which is contact with nature, which has a very healing effect on an individual. So we need lifestyle medicine. We need a good cardiorespiratory assessment. And again, it's my own personal obsession with respiratory status because when women come in, they need to oxygenate. And if they cannot oxygenate, then the outcome is not going to be good. We need medical meals. We need vouchers for produce. And we need to sometimes ignore the guidelines, because the guidelines now say that a woman who's obese can gain between 10 and 20 pounds. I'm sorry, it's nonsense. Every high BMI woman that I've ever had and that I've ever taken care of, and that includes diabetics and hypertensive and everything, I always tell them, I do not want you to gain a pound. If you don't gain any weight, your chances of having a vaginal birth really, really go up. And I would be willing to go against any scholarly academic organization on this matter. Sometimes they need a social worker, and group visits, what they call centering, can be very effective because it's an automatic support group. This is what high BMI women need. Now, we also need to educate, and we need to give warning signs. So these are two beautiful posters from the American College of Cardiology. And if you look in the round buttons, look what it says here. Pregnancy can be nature's stress test on the heart. Isn't that true? Checking my time, talking too much. And here, heart disease is the leading cause of maternal death. So these are very important, frank posters, and these could be distributed, and it can be a springboard for an educational session. In addition, we can also teach patients about epigenetics. I'm not going to get into that now, except to say that our body has the ability, based on our lifestyle choices, to turn on and off genes. So if we want to turn on our good genes, we need the polyphenols, which is the fruits and vegetables, colorful foods, as I mentioned, the B vitamins, physical activity, stress reduction, healthy diet. And you see what's written there: negative sugar, alcohol, saturated fat, processed food, and an unhealthy parental diet. We want our children to be healthy. And what's the goal in this prenatal care? For me personally, as an OB, to pull through to term, to not be induced before the baby's time, and to even be a candidate for spontaneous labor. Doesn't that sound strange? But that's what high BMI women are almost always facing, is an induction. And the fact is that high BMI women are more likely to be induced because of all of these illnesses. And any way you name it, everyone's always looking for an excuse to induce. Now look at this. This irks me, and I always show this slide. I'm going to explain it to you. A predictive model for failed induction of labor among obese women, okay? This came out in 2019, and what they do is they make a calculation. How old are you? How tall are you? How much do you weigh? How much weight did you gain? Do you have hypertension? Are you diabetic? Are you Medicaid? Did you have a prior C-section? Of course, that changes it. Or a prior vaginal birth. So they do this, and they make a whole thing, a whole cookbook thing, and they figure out that this kind of patient has a 67% chance of failing an induction. And then what do? They go to the patient and they say, listen, you have a 2/3 chance of failing. Do you want to just go straight to a C-section? No. So what I try to do is I try to say, okay, the weight gain was 40 pounds for this patient. Let's make the weight gain 0. Let's see if we could change the statistics. I never use this. I judge everyone individually, but I want to tell you it is being used. So there is a lot of research now, and we need so much more research on the microbiome in pregnancy and a newborn and childhood. So there's a beautiful study. Dr. Christopher Gardner now is recruiting women. I think they finished recruiting them. They are dividing groups of pregnant women into fiber-rich food, fermented food, which I didn't get into today. They call it the Fee-Fi-Fo moms. So they're going to be studying a cohort of women, and they're going to be given different diets. They're going to be drawing blood, studying their poop, and you're going to look at the characteristics of the microbiomes of the pregnant women, newborns, and I believe it's going to go up to age 5. So this is an ongoing study, and it's really fascinating. It's so fascinating. This is Maria Gloria Dominguez. She doesn't know me, but I'm a fan of hers. She is a researcher in the human microbiome. She's over in Newark, in New Jersey. What's the name there? It'll come to me. She was previously at NYU. So she has studied, we all know that babies born by cesarean are at a disadvantage in terms of their microbiome because they don't go through the birth canal. So she has studied actually swabbing babies with vaginal secretions to see if it can improve clinical outcomes. This is an ongoing project. There's a lot of research going on. And she brought up the most interesting thing that I didn't even understand until now. Why is it that our bowels are next to our birth canal? And she has studied and shown that the vaginal microbiome changes during the 9 months of pregnancy. And toward the end of pregnancy, the microbes that live all over the body start to migrate toward the vaginal area, so that when the baby is born, it will get an inoculation of all the important bacteria and microbes that it needs to start a healthy life, especially relating to the immune system. And so she believes that it's a wonderful kind of brilliant arrangement that the stool is coming out when the baby's being born, because if the mother has a healthy microbiome, the baby's just going to catch that on the way out. So this is more research ongoing. It's fascinating. The last thing I'm going to talk about the newborn microbiome is how do these bacteria that are inoculated into the newborn through the birth canal, how are they going to eat? You cannot tell a newborn to eat a stalk of celery. So it turns out that the mother has in her genome the ability to produce something called HMOs, human milk oligosaccharides. This is food that is not meant for the baby. The baby cannot digest these sugars. These are sugars that the mother has the ability to produce in mother's milk. And when the baby drinks it, these sugars pass through and go into the large intestine. And the bacteria that are living in the newborn's large intestine will consume these HMOs and will help the baby's immune system to form. It turns out that the baby's gut is slightly leaky. So these HMOs that the mother makes, there are over 200 of them described so far, can leak into the baby's bloodstream and go around and gently knock on the immune system. And slowly, slowly, the baby's immune system wakes up. This is just miraculous in my mind. There's so much more to say about it, but we're out of time. Last but not least, everybody's favorite disease, polycystic ovary syndrome. So this is about poor diet and poor lifestyle. Let's just go to the last column, which leads to impaired follicular growth. It means the egg doesn't grow properly. It doesn't mature properly. It doesn't fertilize. It doesn't implant. And there are more miscarriages. So our lifestyle and, again, the endocrine disruptors are leading to this. So here I just want to show you a picture. Where are we? We're 7:39. Here's a picture of a calm, normal ovary. It's not really doing much of anything. It's happy. It's sitting there. But look at this poor ovary. This is a polycystic ovary. This ovary is on overdrive. It's trying so hard to create a dominant follicle, one egg that's going to ovulate. But because the hormones are so out of balance, it just keeps making these wannabes. These are all the wannabe eggs that never got anywhere. And the stroma, which is the tissue inside over here, these are the hormones that are being secreted in excess to try to stimulate, to try to get there. But because of the imbalances that cannot be overcome, ovulation doesn't occur. So here I'm just going to show you the healthy ovary that made the solitary dominant follicle that is going to ovulate. And here it's post-ovulatory. This little cyst turns into the so-called corpus luteum, which makes good hormones. And the final goal is this. This is the uterus. And here you have a gestational sac with a little circle inside that we call a yolk sac. And this is our dream, that we should have a healthy pregnancy. In another few days, you're going to see a teeny weeny baby with a heartbeat. I'm just going to go over two case studies. They're actually my personal patients, one married, one unmarried. And I think I'm just going to skip it and just tell you that I had a 25-year-old married for a couple of years, and she was trying so hard. And she was shaped like an apple, the typical PCOS. I worked on her together for 6 months, lifestyle change. I just could not, she just wasn't there. I sent her to the fertility doctor, and she was back in my office with a positive pregnancy test so quickly. And I truly believe that we laid the groundwork with all those lifestyle changes that she responded so well to the fertility treatment. And this slide, I would never make such a slide. You have to forgive me. But I followed this patient for 4 years. She came to me when she was 16 years old. She's 20 years old now. She had a beard and irregular cycles with PCOS. She was a thin girl, the worst PCOS I've ever seen in my career. Her hormones just kept getting worse and worse. I sent her to a medical endocrinologist. He kept telling me it's PCOS, put her on metformin. She tried it, didn't like it, put her on birth control pills, tried it, didn't like it. She was willing to take something called ovasitol, which is a supplement to help as an insulin sensitizer. Didn't go for that either. And finally, things were so out of control that I just decided, I sent her to someone else, and we did an MRI of her adrenal glands in case there was something wrong there. Nothing. It's PCOS, the most brittle PCOS I have ever seen in my career. And now she's 20 years old. I gave her a whole speech about the microbiome and endocrine disruptors. Anyway, she made a resolution. She's going to do it. I also gave her fermented foods. Within 3 months, her hair growth was slowing down on her face. She literally had a beard. She called me up. She was having spontaneous cycles. The staining stopped. She felt so much better. And she also stopped using plastics, especially with hot food, et cetera, et cetera. So I just want to tell you that this works. Lifestyle works. I'm finished. It's my last slide. And I just decided to put it there because I know your organization is very idealistic. And my favorite movie is The Sound of Music. So I just thought I would put in from Climb Every Mountain. A dream that will need all the love you can give every day of your life for as long as you live. Climb every mountain, ford every stream. Follow every rainbow till you find your dream. Thank you very much.
Thank you, Dr. Mann. Really, really phenomenal information and stories, and just the realism of what it means to be a health practitioner at this moment in history when we're dealing with such an epidemic of chronic disease and how it affects maternal health. I have lots of questions for you, as do many people in our audience, and I invite everybody watching us live to please share your comments. We're really happy to dig into some questions, and we'll stick around for another good 20 minutes to go deep into these. Dr. Mann, let's talk a bit more about nutrition. And what I want to do first is to talk about the role of nutrition in obesity, and maybe to help make it even more explicit for our listeners about how eating unprocessed plant foods can aid women in achieving a healthy weight. What are some of the main talking points that you would like to share about that?
So a lot of obese women say to me, I hardly eat anything and I just cannot lose weight. And they tell me what they're eating, and really they're not eating a lot of food. They're not eating a lot of calories, but they're also not eating fiber. And a lot of times they're eating a cookie and a drink. And then at night, then they start the eating. This is like the classic kind of thing that I see. The ultra processed foods are devoid of nutrition, and they leave us looking for more food, more calories. And if all we've got around is more of the empty calories, we're just going to keep going and going. And then that also starts the cycle of guilt and shame. And the patients feel helpless and they can't get out of that. The way to encourage the patient is to say, listen, you have to do the fiber foods. I'll show you the list. A little fermented is probably also going to help. You have to remember you can get protein from beans. And I start going through basics, and then I see about their level of readiness for change, because if you go overboard, they're gone, they're out the door. So it really has to be customized to each patient.
That's great. Can you say more also about, if somebody is pregnant and comes into you and is already sort of on the path what would you say to them about their diet during pregnancy? And also, let's say for healthy weight women as well, what are some of the cornerstones of that? Is there anything like special for someone who's pregnant when it comes to nutrition?
So women and society as a whole, they're protein obsessed, right? They're afraid if they don't get the protein, then it's going to be a catastrophe. So I do talk to them. I don't ignore that protein issue. And I explain to them that soy is a great way to go. I encourage tofu, tempeh, edamame. I push all of those. There are also certain beans that are more known in the Middle East, like tormuz, for example. Those beans are only, let's say soy, let's say would be the highest in protein. Tormuz is second to that, a very delicious bean that's very high in protein. And I kind of tell them to build around nuts and seeds, vegetables, whole grains. I explain to them that we're not getting into that today, but that whole grains are a very significant source of protein. We talk a little bit about combining foods. That's the protein. And then the other thing they want is their baby should be a genius. So I talk to them about maybe fatty fish, stick to the sardines, mackerel, herring, wild salmon. I tell them to stay away from fried foods, etc., and to really watch. And really, what I tell them at every single visit is, can you please do me a favor and don't eat junk food? That's a one line that any physician or provider, any midwife, nurse practitioner, PA, anyone can say to their patient, please do me a favor and don't eat junk food.
Yeah, great. Tell me a little more, because fish is often off the plate for people who choose a plant-based diet, but there are certainly certain fats that are helpful for women who are pregnant. And you mentioned that it's the smaller fish that you're advising these women to eat during pregnancy. What are the considerations here?
So the smaller fish are less likely to have toxins. They're eating the algae directly, and so women can choose those fairly freely. A lot of the larger fish have accumulated toxins, and the quality of the omegas in these small fatty fish, that's very, very high. So you could eat, let's say, 2 servings of sardines a week and you're good. And so that for those who choose that, there are many healthy women, and there's plenty of literature and plenty of YouTubes of all the women who are eating flax seeds and walnuts and soy, chia seeds, and all the rest of that, and banking on their body's ability to convert these precursors to the long chain omegas. But that's an ongoing controversy, and I like to stay away from those controversies.
Of course. Thanks for entertaining at least the beginning point of that. I also want to go into some questions that have come up. First of all of the information that you gave about the microorganisms and the migration to the vaginal cavity for the baby's birthing is just amazing. I hadn't heard of that, and it sounds like everything about the body just like makes me think about how miraculous the systems are that we've evolved to have over time. Now with the breast milk itself, and you talked about human milk oligosaccharides, there was a question in the chat about how breast milk changes over the course of a baby being breastfed. Do you know if those HMOs, the oligosaccharides, do they reduce in concentration as the mother continues breastfeeding, or does anything change about the breast milk over time?
Well, you have to assume that until the baby's taking solids, that the only way for these microbes to survive, and they need their calories. So it is an ongoing component of breast milk. What happens when the baby starts to take solids? I would assume that everything changes, but the complexity of that is probably beyond our scientific knowledge at present.
Mm-hmm. It's amazing, though, the interplay of the immune system and the nutrients that we women naturally produce. It's phenomenal. For any woman who may be having challenges with lactation, do you want to comment on nutrition for the baby postpartum if a woman needs to use formula, for example?
Well, I try to tell women, even if you can only nurse once a day or twice a day, just do that. because all of that goodness is going to get into your baby, and it's going to help your baby over the long run. We all know, I didn't get into that, about babies who are breastfed are less likely to be obese, less likely to have allergies, et cetera, et cetera. So whatever amount of milk you can feed, do that. If your baby will not latch on, try to pump. There are many types of pumps out there, and give whatever you can. Occasionally, we will even recommend a milk bank under certain circumstances. So these are all things to consider. As far as formula, I was raised on formula. Here I am. Way back in the 1960s, the formula companies were trying to convince women that their formula was healthier than mother's milk, and my mother bought all of that nonsense. So yes, it is possible to make it through on formula, and please do away with the guilt and the shame and all of that. Sometimes you just have to do it.
Thank you. So important. I want to transition to talking more about fertility. There are polycystic ovary syndrome is obviously a big, let's call it a culprit in fertility issues, but it's not the only one. I'm wondering if you could talk more about diet and fertility. We know that ways of eating will address some of the underlying issues with PCOS. Can you go deeper into what the most important aspects of fertility and nutrition would be?
We're talking about women who need to watch their calories, or women who might be normal weight and still having issues.
Let's take them one at a time. Yes.
Okay. So I didn't really talk about the Mediterranean diet. There is definitely a signal there that the Mediterranean diet is very good for fertility, as the vegan diet is, or what we call whole food plant-based. Both of those diets are very good. But what I caution patients is, please don't misunderstand the Mediterranean diet. It doesn't mean pouring olive oil on everything. The healthiest greens that you can eat are actually herbs and spices. So if we're looking to really ramp up our health and our antioxidant potential, I call the antioxidants the cleanup crew. We all do that. So you really should have a lot more leafy greens, and especially herbs and spices. That is going to definitely help with pursuit of fertility. Does that help? What else would you?
I don't know. I think, we have a question. What do you recommend nutrition-wise for conception? I think there's the issues of the follicles and PCOS. There's, in my condition with endometriosis, I think 50% of women with endometriosis end up having trouble with fertility as well.
Yeah.
What more? There might be a bit more here.
So the supplement that is good for PCOS is called ovasitol. There are other supplements that it's called myo-inositol, and it is an insulin sensitizer. We know that women with PCOS have insulin resistance, right? Mm-hmm. So this particular supplement is good for that. But the interesting thing is they make myo-inositol from food. And if you look at the components of that, you can have almonds and cantaloupe, and you're getting myo-inositol in the food. But maybe you need a supplement because your body is really out of balance. So in those cases, we try the myo-inositol. Also, we could try building a little bit of muscle, because muscle helps decrease insulin resistance. So yes, aerobic exercise is good, but resistance training is also good. And all these things I'm saying, they're all good for everyone all the time, right? But in PCOS, you're looking like decreasing insulin resistance. So you have to think kind of like the diabetic idea of that, even if they're not diabetic, but it's the same underlying mechanism.
Yeah, and that's really huge. That's something that was very interesting to me when I first started learning about PCOS, that diabetes fundamentally has the same disease process as PCOS. And in that way, we talk about how the dietary fat that we consume can interfere with insulin sensitivity. And so do you want to say more about maybe how we would deal with that?
With dietary fat, I used to tell my patients who had irregular periods to drink whole milk. There is data to support whole dairy and especially whole fermented dairy, but really what I talk to everybody about now is fiber. That's all. I just talk about fiber. People ask me, where to get your protein from? I ask them, where to get your fiber from? Do you know how many grams of fiber you need to eat in a day to be healthy? So the minimum amount is 25 grams of fiber. Those patients who are talking high protein, low carb, they're not getting the amount of fiber that they need. And in order to get your 25 and even better 35, if you're dealing with some kind of metabolic dysfunction, you really have to sit there and count it out. An apple, let's say, has 4 grams of fiber, and you don't want it to be added fiber. You don't want to pour fiber on your food. You want it to be fiber in a whole, intact plant food. And that's going to be the most health promoting.
Great. Do you think for folks who are dealing with fertility issues, maybe regardless of condition, do you think that they need to hit a specific, I want to say a specific diet quality in order to achieve fertility or to achieve conception? Or is this something that will be very variable depending on the woman?
Funny enough, a lot of women can get pregnant eating potato chips and soda. And why is it that some can do that and become pregnant and stay skinny and all of that, and then others cannot and they struggle? I don't have a great answer for that, but I could say it's not only about becoming pregnant, it's about a long and healthy life. So whatever you invest now, you're going to reap later on. So the more changes you make, the better off you are. Is there a threshold? I would not say there's a threshold. No.
Mm-hmm. Mm-hmm.
No.
Okay, very helpful. There was another question about using GLP-1s for, of course, addressing high BMI, but also for something like PCOS. Is there a time and place when you think that these GLP-1 inhibitors, these are the drugs that are anti-obesity medication in the popular narrative? What do you want to say about that?
I thought there was going to be a question about that. So first of all, what do I think GLP-1s are best for? They're best for advanced diabetics who have compromised kidney function. So let's put that there. Everybody else, it's sort of like, how much of a hurry are you in? One of the biggest problems with these drugs is the slowing down of the gastrointestinal tube, and motility is a sign of gastrointestinal health. So I like to say to people, these drugs work by making you sick. It slows your GI system down. There's no doubt about that. The studies show now that if a patient needs anesthesia, that they want them off these medications for 3 weeks in order for the stomach to empty out. So I'm going to say my answer to your question is, it depends on how much of a hurry you're in. If you're in a hurry to get pregnant and nothing's helping you right now, and you don't want to take the 3 to 6 months to do it with lifestyle, take it. What can I tell you? I don't really have another answer for that. But remember that of all the diet drugs that have been given over the years, and especially compared to lifestyle, 40% of the weight that you lose is going to be muscle. So anyone who goes on one of these drugs, they have to have a very strenuous muscle building regimen. And who is ready to do that? But if you don't do that, you will wind up losing a lot of muscle mass. And that's why we talk about Ozempic face and all these other kind of Ozempic looks, because they've just lost that critical muscle mass. That's my take on Ozempic. I have an article on Ozempic I wrote for Women's Magazine.
Right. Maybe we can circulate that later for anybody interested. That would be excellent. I want to shift this because, we didn't really touch on endometriosis, but we had someone ask about a late stage diagnosis of endometriosis at the age of 70 post-menopause. What's happening in the body when something like that happens, when we have something that might be more related to the reproductive system during its fertile phases compared to later in life?
You're telling me that a woman who was postmenopausal for 20 years got endometriosis? For me, until proven otherwise, I would call that a neoplasm. I would call that a tumor. I would call that an abnormal growth. I wouldn't think of it as someone who is still making those kind of hormones, like a reproductive age woman to have endometriosis kind of makes sense. A postmenopausal woman does not make sense. Does she have another tumor somewhere else that's secreting estrogen and progesterone, for example, that led to that? Otherwise, it might be a tumor in and of itself. It needs to be investigated.
Mm-hmm. Thanks, really helpful. Thank you. I don't see any other questions coming from our audience. This was very informative and just so interesting to go into the depths of these details with you. Do you want to share any closing words with our audience?
I think that people get fooled because they see high BMI women functioning and doing everything that we need to do. And I just wanted to raise awareness that going through labor and delivery for a high BMI patient is a test. And we have to do everything with our resources to be inclusive of them, women in their 20s and 30s and early 40s, to really try to optimize them so that when they walk through the door of the hospital, they could be confident of having a good outcome.
Thank you. Wonderful. And I just want to share some of the great feedback we're getting from everybody in the room. You're
it's
excellent.
All real. It's all real what I'm telling you.
It's all real. I know.
All real.
Well, thank you, Dr. Mann. It's been a pleasure. And we will be very privileged to learn from you again in the future. Thanks so much for sharing all of your wisdom and experience.
Thanks to everyone.
Thank you. So for everybody who has joined us this evening, if you would like to learn a bit more about Dr. Mann, she does have some YouTube videos up on her channel. I'm going to put a link in the feed if you'd like to go find those. And of course, you can always tune in and see many different videos from Plant Powered Metro New York on our YouTube channel. For those who may be watching on other platforms. I want to give a special shout out of thanks to our Plant Powered Metro team members, Karina Pierce and Jim Spellos, for supporting our live stream behind the scenes. And again, to Dr. Nasolo Teddy and the wonderful and engaged HeartSmarts community who joined us this evening and each night of our series. So looking ahead, we invite you to join our next Women's Wellness and Food session, which will be with Dr. Elizabeth Fontaine, joining us from Vermont. We're going to be talking about nutrition for healthy menopause and perimenopause. You can learn more about the whole series at our website at the link that I will share in the chat right now. So here it comes. And sign up. You can join us, register for a reminder, and we will be sure to get that in front of you. Please, if you're joining us on YouTube, subscribe to our channel. You'll get notices when we go live. And you can always visit our website to learn more about all of our social events and our learning events that are coming up. I also want to invite you, if you found value in tonight's program, to please make a donation toward our free and low-cost programming that we offer the community on a very regular basis. It is our privilege to bring this to you, and every little bit helps to make it possible for others. So from all of us in the studio, I want to thank you for joining us and wish you your best health. Take care.